Welcome to all those who are online with us today. There are many of you from all around the world, and also to the standing room only audience in the room. So my name is Professor Helena Teede, and I'd like to just start by acknowledging the traditional owners of the unceded land of the Wurundjeri and the Burrung people, and recognise their continuing connection to the land and waterways. And we pay our respects to their elders, past, present, and extend this to all Aboriginal and Torres Strait Islander people who are with us here today. I'd also like to note our MP, Dr. Carina Garland, who I will introduce formally shortly, and also many of our guests today who are members of the multiple 39 organisations across 71 countries and who've worked with us tirelessly to produce these guidelines. So I wanted today just to cover briefly, before I introduce Dr. Garland, what polycystic ovary syndrome is. So really importantly, it is not a disease of the ovaries, and affected people do not have cysts. So it's a misnomer that was named incorrectly on inappropriate translation of knowledge we didn't have at the time. It is actually a complex condition that affects 1 in every 8 Australian women and women around the globe. It is underfunded, undertreated, under-recognised, and very much neglected and dismissed. It's often put in the box of being a gynecological disorder, and only gynecologists are really trained in that area. In my medical degree at one of the top universities in the world at Monash, I had 1 hour of lectures by a gynecologist on PCOS. One of the other leading researchers in the world who's in the room, Associate Professor Lisa Moran, said the dietitians get 10 minutes in 4 years. So really we have a lot of work to do. We need to get more funded research, more education, more awareness, and more accurate information out there. It is a complex condition. It has significant psychological features, with 70 to 80% of those affected having depressive and anxiety symptoms, and it has a greater impact on quality of life than, in fact, conditions like diabetes. It has significant metabolic features, much earlier onset of diabetes, earlier onset and higher risk of heart disease. Much easier to gain weight and harder to move it. It also has significant reproductive features, including reduced fertility, but women with this condition can have children with timely diagnosis and help. And then also has other features that really affect people with the condition in a way that it can often attack their femininity and sense of self. So, for example, excess body hair, we have apple shapes instead of pear shaped. So women or those affected often get weight accumulation around their tummy. And all of those factors, plus often not having a diagnosis, leads to a situation where people are just lost and not feeling supported. And that, of course, makes the body image and self-esteem issues, etc., worse. So that's what it is, a complex multi-system condition that is individual for each person and changes over the lifespan and needs personalised therapy. So why the guideline? So you'll hear from Lorna later today, who's been working with us for a long time, along with consumer groups across the world and input from over 5,000 health professionals and women with the condition and those affected about what we needed to do and why. Essentially, because it is neglected and because we have so little education and limited research, guidelines were critical to make sure that we had a consistent evidence-based message to all health professionals and all those affected. And that's what we've delivered together with our partners across the world. This guideline is for those who have the condition and all the health professionals who partner with them, but it's also for the universities that educate our health professionals and for the funders that fund research and governments that set up models of care and health services. And you'll hear more about that from today. So essentially this guideline and the extensive translation program that has been developed by this amazing team actually already reaches 196 countries. It already reaches over 50,000 women. It's multilingual, and the impact that we know that's having and on the new models of care will be quite substantial. So it's not just the research that we do with our partners. It's not just the guideline. It's not just the translation efforts. It's about making an impact with and for those who are affected by the condition, who've gone on the whole journey with us. So on that basis, I'll talk a little bit more about the main outcomes of the guideline shortly, but I'd like to introduce Dr. Carina Garland MP. Welcome. So Carina, so fortunately for us, Carina is actually an academic. So Carina studied at Monash and is the local MP for our region. for the federal government. She's actually an alumni with a Bachelor of Arts from Monash University and has a major in English literature, skills of which we all need to communicate and write so much about this condition. And essentially has had, as I said, has had a PhD in the past. She's dedicated much of her professional life to working for better health and better wellbeing and secure environments for her constituents, and also has a passion for women's health, which we've been fortunate enough to share with her. So essentially, with no further ado, I'll introduce Dr. Garland to tell you a bit more about the condition and the guidelines.
Thank you so much for having me here. And I want to begin by acknowledging the Wurundjeri and Bunurong people of the Kulin Nations on whose land we are gathered today, and also acknowledge the lands of people joining us from other parts of the country as well, and pay my respects to elders past and present, both here on the Bunurong and Wurundjeri lands and elsewhere, and acknowledge all the First Nations people who may be with us today. It really is an honour to be here today to officially launch the 2023 International PCOS Guidelines. And thank you so much, Professor Helena Teede, for the generous invitation to be here today too. Thanks to Monash, the Monash Centre for Health Research and Implementation, and Monash University for hosting this wonderful event, and for always being so welcoming to me when I come to visit. This guideline is the culmination of so much hard work from hundreds and hundreds of people right across the world. There were 750 healthcare professionals and consumers involved in the development of these guidelines. And this is a truly multidisciplinary, diverse group of people. I'm not from the medical sciences myself, but have worked in multidisciplinary teams myself. And I just know that you get such excellent outcomes when you are able to collaborate in multidisciplinary ways. I really want to acknowledge the passion, dedication, and expertise of every person involved in the development of this guideline. It's an incredible achievement, truly. And I want to acknowledge today, while we're talking about women today, we acknowledge that not everyone who is affected by polycystic ovarian syndrome identifies as a woman too. Historically, it's no secret that women's health conditions have been overlooked. When I speak to women about women's health, everyone seems to have a story of having to present repeatedly to doctors to finally get diagnoses, being really frustrated, and the toll that does take on people's mental health as well as their physical health, of course. Women's health has simply not been prioritised for too long. So generations of women have been left undiagnosed, misdiagnosed, untreated, and dissatisfied with the care they have been provided. And women's health has been neglected. We deserve more, I think, and I'm really excited with the work that's happening here, which is finally starting to put things to right for so many people who've suffered unnecessarily. We deserve more research in women's health. We deserve to have women's health be seen as a priority. We deserve to have accurate and timely diagnosis and treatment of conditions that affect women. The 2023 International Polycystic Ovary Syndrome Guideline puts people with PCOS at the heart of the recommendations. It's really important. Patients and consumers were engaged through the development of the guideline, and the experiences and perspectives of patients were really prioritised every step of the way. I think that's just so empowering for those people who have shared their stories and their experiences. I know that Lorna Berry, who we'll hear from shortly, was hugely involved as the consumer representative, making sure that the patient perspectives and priorities were at the forefront. In reading the guideline, the importance of education, patient empowerment and shared decision-making is very much emphasised, and that is just excellent. As we heard from Professor Teede, PCOS is a highly prevalent condition affecting about 12% of women, but it's underdiagnosed, under-researched and misunderstood. And I think there is no sharper way to understand that misunderstanding than the name that we refer to the condition with. It's been misclassified as a reproductive disorder of the ovaries, despite the far-reaching implications of PCOS on metabolic, endocrine, dermatologic, psychological, sleep and pregnancy health. PCOS is something I deeply care about. My sister has PCOS. I've got friends with PCOS. 1 in 10 women worldwide have PCOS, or 1 in 8, as we heard before. So I need to update my stats. So the odds are that we all know somebody who has PCOS. I've witnessed the journey that my sister has gone through to get her PCOS diagnosis and then manage the condition. And sometimes the less than helpful advice that she has been given, it's a lifelong condition. So she will be going through this journey for many years to come. I know that the contents of this guideline will be very affirming for women across the world with PCOS, including the many women in my own electorate of Chisholm who were affected by PCOS. This is going to be affirming for my sister, my friends with PCOS, and all of those women who have suffered not being listened to over the years. These guidelines recognise the wide-reaching health implications of PCOS, the complexity of the condition, the inconsistent care women experience, the delayed diagnosis. The guidelines recognise the pervasive weight stigma that impacts many women with PCOS in all settings of their life. Like many women's health conditions, PCOS has been grossly under-researched and neglected. Although this guideline is evidence-based, the contributors, I know, emphasise that the research and evidence into PCOS is low to moderate in quality. PCOS is a serious condition with serious effects, impacting millions of women in our country. It deserves more attention, more research, and continued investment. The government that I'm part of, the Albanese Labor government, is prioritising women's health, and I think it's about time that governments take this step to do so. This year, we granted a substantial increase in funding through our Medical Research Future Fund to support the development of PCOS resources and tools, including the Ask PCOS app. This funding will advance personalisation, interactivity, self-management, and the analysis of individual data. It will aid shared decision-making and improve information, models of care, and support for people with PCOS. It will also mean that the Ask PCOS app will be upgraded to 11 languages, expanding on the 4 languages the app is currently available in, and that is really exciting. It means more people will be able to access information that they need. The launch of this international guideline today is a testament to the truly world-class work into the assessment and management of PCOS that is happening in Australia. This international guideline was led by Australia, and the Ask PCOS app was created here, and we are seen as leaders on PCOS globally. And we're seen as leaders globally because of the leaders in this room, because of the tireless efforts of researchers, clinicians, healthcare professionals, academic experts, and women's health advocates. I want to reflect too on quite a remarkable figure, which is that the Ask PCOS app is used in 186 countries by almost 40,000 women. That's incredible. 40,000 women empowered with that information where they otherwise would not have been. And I know that Professor Teede and her team are just getting started. The next iteration of this app, which will follow the launch of this guideline, will be even more comprehensive, and the translations for this guideline will be extensive. More tools, I know, are being developed to support people with PCOS, and that is a fantastic thing. We know that these tools have been woefully lacking, and I really want to pay tribute once again to the foresight of and the expertise of people in this room for, making sure that people have the tools that they need to manage their condition. We know many people with PCOS have been left feeling dissatisfied with the care they are provided with. Many are undiagnosed or untreated in the community, so there'll be people that just don't know that they have this condition. Many women who do have the condition and may know about it may not have all the information they need about the multitude of health impacts of PCOS. So the launch of this guideline today is a really important step in improving care, health outcomes, and the quality of life for those with PCOS. This is going to improve diagnosis and treatment of PCOS globally. It will improve the quality of life of the 12% of women we know are affected by PCOS. It will make a real difference in the lives of women in our community, and that cannot be emphasised enough. So on behalf of the Albanese Labor government, I want to congratulate everyone that has been involved in the development of these guidelines for your incredibly important work. I am so grateful sincerely for all the work you do for women with PCOS, and it is an absolute honour to be here today celebrating the launch of the guideline. Thank you so much.
There you go, more passionate women talking about women's health. So on that note, I'm going to introduce Lorna Berry, who is an expert in lived experience of PCOS, and she and many, many others have been on this journey hand in hand with us the whole way along. And so I'm going to let Lorna give you her story and her perspectives.
Thank you, Helena, and thank you everyone for coming today to such an important launch of such a big piece of work. So I'm Lorna Berry, and I was diagnosed with PCOS about 20 years ago in my early 30s after reading a magazine article in the UK when I'd been travelling, and I had wondered all of my life from the age of about 13-ish, why my weight had fluctuated so much and why my cycle was irregular and why at 25 I couldn't get pregnant with pretty easily with my first child, who's now 26 years old. And when I read this article, I went, oh, I identify with all of these different symptoms, so hair on my face, irregular cycle, fluctuation of weight, all of those kinds of things that affect women with PCOS. So I went to my GP, who dismissed me. I went to another GP and another GP, and they all dismissed me until I found one that sent me off for an ultrasound, and hey ho, there we go. Had this diagnosis, which was like the missing piece of puzzle. So women with PCOS have to fight for diagnosis. We also have to fight to survive, because people comment on your weight. Or even last week, someone said to me at a pretty significant family event, oh, you've lost weight, which I have not. But that was the first thing they said to me. So I hadn't seen them for a few years, and that was the first comment to me. And that has happened to me many times throughout my life. This morning, my husband made me a cup of tea, and I was sitting looking at Facebook, and I had a Facebook memory that came up. And a few years ago, I was told that a 40-day water fast would cure PCOS, and that was all mindset. So this guideline is so important, so we don't have all of that untrue information out there in the wild with people passing an opinion, because everybody has an opinion. So evidence-based research is so important. That Ask PCO app has all of that in it, and that's really powerful for women with PCOS, because one thing that we're really good at is advocating for ourselves when it comes to going to our doctors, because we've had to be, because that's how we get heard. We want to be seen, we want to be heard, and we want to have validation about what's going on for us. So a friend of mine recently was at a fertility specialist, not there for fertility, as a gynae as well, and he said, oh, your truncal obesity, which hurt her very deeply, because God knows, you know, when you have truncal obesity yourself. So, you know, that sort of stuff just can't continue to happen for women. This is not a choice. When my 26-year-old daughter was about 13, we were at the GP one day, and she was having really bad, heavy periods. And I said to the GP, oh, I have PCOS. And her response to me was, did you diagnose yourself off of Google? And I'm like, no. And then she looked at my daughter, who is a very slim woman, and said, well, she won't have it, she's thin. Right, and I would hazard a guess that she does have it, because she's her mother's daughter, and my 10-year-old, I would hazard a guess that she is coming up through those ranks as well, because it's genetic. So, yeah, a real great privilege to be part of this process and advocate for other women with PCOS, and their work can only continue, and the name change, I think, will make a big difference, because this, when you say cystic, people think it's something far more sinister than it is. So, yeah, thank you for listening.
Thanks very much, Lorna. So on that note, if I get this right, I am going to just play you this very brief video. There we go. Get rid of those. And
Hello, my name's Professor Helena Teede, and I'm really proud on behalf of the 6 continents, 71 countries, 39 consumer and professional societies, and over 100 people who've worked very hard to bring you the 2023 International Guidelines for the Evidence-Based Treatment of Polycystic Ovary Syndrome. This is a very common condition affecting 1 in 8 women around the world. It is neglected, misnamed, there are no cysts, and has broad and complex features over a woman's lifespan. These guidelines aim to improve the quality of care, quality of life, and health outcomes for those affected, and they were developed very much hand in hand with those with a condition. We commend to you the guideline, but also the extensive translation resources which provide information are already used in 196 countries and now are extended and updated to ensure women and their health professionals and those with PCOS have the most up-to-date information to help improve outcomes. Thank you.
basically the media a lot today promoting that information. At this stage, I'd like to just run through what some of the top major changes are that the guidelines actually advocate. But before I do that, it's just really important that I thank and acknowledge a few people. So thank you, Dr. Garland, for coming today and for launching the guideline. But this has been a massive effort. To give you an idea, there is over 6,000 pages of evidence synthesis that inform this guideline. Now, I dare anyone to read it. I have, and there are a few others who will read every bit of the detail. But a lot of that had to do with the incredible idea and due diligence of some of our early career researchers and clinicians, Gillian Tay, who's in the audience, and Aya Musa, who did a great deal of work to bring together an early career network around the world, who did the work to put that together. And there are many members of that early career network in the room today. I'd also like to seriously commend Susan Baker and Rhonda Garrard, who are the lead of our translation team, tirelessly. They were emailing me at 4 o'clock in the morning. Yes, I was awake because they were finishing off the last touches here, but allows us to have this phenomenal, innovative platform that actually can reach so many people. Many of the people who contributed to the guideline development, including Dr. Joham, who's in the room, as Professor Lisa Moran, who led the Lifestyle Initiative, and the other chairs of the guideline groups who come from around the world, Professor Peltonen, Professor Docris, Professor Boyfin, Professor Boyle, who's actually also from Monash University, and Professor Norman, who's been the driving force behind a lot of this work for a long time. So just to very much acknowledge the fact that this is a huge team effort from early career, from consumers with lived experience, from multidisciplinary experts around the world, but proudly it is Australian owned. And I think if it's a great example of being able to get people together to really make a difference. And I'd also like to note that we've been fortunate enough to get government funding to actually expand our work. And indeed, Professor Vincent is in the audience because we are now co-leading the International Early Menopause Guidelines, which also affect 1 in 8 women, and also have had a lead role in the Unexplained Infertility Guidelines, a very much misunderstood and overmanaged condition. So actually getting consumer information in the hands of people and couples who need it is going to be really critical. So we're extending the successful model, if you like, to many other areas. I'd also like to acknowledge the 39 societies and consumer groups involved who did provide some co-funding and have really participated and collaborated on the journey. So what's new in the guideline? I think, Carina, you highlighted that one of the things about this is it is actually a guideline developed with women, or for those with a condition. And that is different. Most guidelines are developed by often a single group of health professional experts. Often they're not necessarily designed for the clinician at the coalface, for example, the primary care or GP providers. They're often not really done with the sensitivity and care that they need. So there's a big emphasis here on weight stigma. 70% of Australians are above healthy weight, and globally rates are escalating. This is not an individual behavioural problem. It is a government policy systems. There are so many reasons why this happens. And in PCOS, there are additional reasons with the hormonal contributions. And we need to stop blaming individuals because they can't, just eat less and move more and cure themselves. So there is a clear need that we need to provide evidence-based information from an early age on healthy lifestyle. There is no miracle hormone diet. There is no hormone balancing through diet. The water diet, the lemon diet, you name it. People make a lot of money out of it, but there is no best diet. But there is a myriad of healthy approaches to healthy lifestyle that are important from adolescence onwards. And Lorna's daughter's lucky because she's going to get her diagnosis, even be it from her mum, at an early age and get the information she needs. But the guideline spends a great deal of time and effort under the stewardship of Associate Professor Moran and her team around the world around healthy focus of lifestyle and looking after and improving self-care. The other areas that were really covered are the psychological and emotional well-being. So 70 to 80% have depressive and anxiety symptoms, body image, self-esteem, and really severe quality of life impacts. And it is dismissed. And it is dismissed often because of the ovaries and because it's seen to be a women's health condition. And that we need to overcome for many, many reasons. And we are working on changing the name. And the forum on that is later this year. The other important acknowledgement in the guideline is the metabolic risk. So it wasn't acknowledged previously that heart disease was increased because we didn't have the evidence, and we now do. So diabetes and heart disease is the #1 killer of Australian women, and yet we don't perceive it. Our health professionals don't perceive it. We don't focus on prevention. And here's a condition where we need to focus even more to make sure that people understand that. And as someone said earlier today, well, what if I don't want to have children and I still have PCOS? There are many parts of this condition that are important to know about and manage that are not just about fertility. For fertility, the great news is we can significantly improve outcomes. Women with this condition should never be told, or those who are affected, that they cannot have a family before they've had access to appropriate treatment. The treatment, if given timely, because they've got a diagnosis, in a way can be as simple as metformin, like in Lorna's case, really cheap, low side effects, can be effective, through to much more effective modern medications that have more side effects but are still very effective. The important message here for couples or for those who wish to seek fertility is up to 70% with this condition will need help. But the help is generally tablets. There is not necessarily a need for IVF, and very few women and people who are affected actually need to go on to IVF therapy. Knowing that information can make sure you help get directed to the right treatment. But knowing early, planning your family initiation if it works for you, so that you're not looking at age as a fertility factor and all the other things that impact, is really, really important. So fertility is very possible. Help is there. Get diagnosed early and make sure that help is sought. Support for the mental health and emotional well-being, awareness and prevention of the metabolic impacts. The other very important area of the guideline is around the impact of this condition in pregnancy. Now, we know that 12% of women have this condition. In our organisation, and indeed globally around the world, about 2% of pregnant women are even identified as having this condition, and yet they have high gestational diabetes, high preeclampsia. One of our early career researchers, Monash, is in the audience, has done a lot of work on this, and essentially from over 100 studies, we know that this is a very significant high-risk condition, but it's not even recognised. So getting it recognised in pregnancy is going to be critical, and that's work that's currently underway. And then using preventative strategies is really important. Then we extended the evidence and extended the recommendations around treatments. The combined oral contraceptive pill works. Yet the misinformation that's out there on the internet about not using it, or it disturbs your hormones, or all the counterbalancing information of buy my product and it'll work. The reality is the combined oral contraceptive pill is very effective for this condition. The other thing is that laser therapy is also very effective, and we will be meeting with Carina about this, because at the moment you cannot get access to medical therapy or laser therapy, effective not only in treating the hair, but actually improving mood and improving body image and improving self-esteem. But you can't access it unless someone gives it to you for your Christmas present, or they save up to be able to provide access, and that's just not appropriate in our current environment. So we know that it's evidence-based, and we're advocating for greater access. The other area that was important was around, besides weight stigma and recognising stigma of the condition more broadly, there was also a gender inclusive language statement in this guideline, which Rhonda Garrett should be very proud of. We recognise that everyone with this condition does not necessarily identify as a woman, but we also recognise that the majority with this condition do. So our approach was very much one of being inclusive or gender additive. In other words, we use the term woman throughout the guideline, but we also use terms such as individuals or those with, and attempt to be as inclusive as we can, and also acknowledge the unnecessarily polarisation that occurs around this issue. Gender inclusive can be including women and those who don't identify. And that has actually now become a statement for reproductive health guidelines, so it'll be much broader than just our guideline. The other important thing is to acknowledge that that it also is a lifelong condition, and that we need to, as you said, Carina, manage this over the journey throughout women's life. So we now have good evidence on improving diagnosis, and now women do not actually need to have an ultrasound. Now, for those of you who've had the pleasure of having an ultrasound, and for those of you who haven't, it's a transvaginal or internal examination. It is costly, it's inconvenient, it's not something you choose to have. You can now have a blood test as an alternative to that. And so that becomes quite important to make the diagnosis easier. You need to know what you're facing and take that information to your health provider, have a history, an examination and a blood test. You may still need an ultrasound, but that's not for the purpose of diagnosis. I must emphasise that the ultrasound and that particular blood test, which is new in the guideline, is for adults. It's not suitable for adolescents because it's not specific enough yet. So really a lot of new information in the guideline and a lot of emphasis and improved evidence, still low to more moderate quality, but better than it was, on this common and fairly neglected condition. And our next big challenges are going to be around changing the name and making sure that we can get better recognition and get our health professionals better educated. I was chatting to someone from Monash earlier today who was texting the Dean of Education as we were speaking to say we need to do something about this. And we will be writing to all of the major universities around the world to emphasise the need to do this on this condition, but also on women's health more globally. So on that note, I think that the main messages that we have for you today are that the guideline is evidence-based. It's bringing consumer perspectives, multidisciplinary health perspectives, equity and access to the table in its development. It follows the most robust international best practice processes. It is approved by the National Health and Medical Research Council of Australia, and indeed was commended in their approval of that process, and is the only guideline they approve that is international and indeed is truly international. It also very much is supported by translation resources. And so just to highlight this, the Ask PCOS app we've talked about has information that was generated from rigorous research on the top 95 questions that people with this condition have. And it answers those questions. It's got a function at the back end that actually allows you to personalise the information. For example, if your primary concern is diabetes or weight or emotional well-being, that information gets filtered to the top because there's a lot of features of this condition. It can get quite complex. So the translation resources include the app, and that will have many languages, as you said, and indeed with the enthusiasm of the 100+ people directly involved in the guideline, we're now getting it translated into things like Finnish, Swedish, Hindi, and the list goes on. So we really do have a phenomenal number of opportunities to translate into many languages here. We also have a number of fact sheets, consumer booklets, GP tool, and many other resources. And this will be presented at over 100 international conferences. It's already been presented at the largest major meetings in our fields internationally. And it's brilliant to see that that information is actually getting out there. We have groups such as the College of Radiologists who recognise that there's a much greater need to understand the role of ultrasound and quality reporting, and also that the ultrasounds have a role in this condition, not necessarily only in diagnosis, but actually in the features of the condition over time, especially, for example, around infertility assessment and management. And getting good quality reporting, especially if you're in rural and regional Australia, is really hard. So it's fantastic to have the college as one of our partners. College of Obstetrics and Gynecology, Endocrine, the Psychological and Dietetics and Exercise Physiology societies are all on board in Australia, and then internationally all of the major stakeholders. And we also this time had a lot more engagement from other continents, from South America, from all throughout Asia, where 60% of the world's population lives, but which is often neglected, and for Australia, where many of our immigrant populations come from. So that translation program is pretty much unparalleled and gives us great satisfaction to generate and to share. And we hope you will make sure that message gets out there and beyond. So on that, I'm just going to hand over quickly to Dr. Angie Johan, who I've had the pleasure of working with for a long time, mentored since she was a registrar, who is a leading clinician and actually academic in her own right in this field. I think you're actually ranked about 6 now, which is fantastic. And we're going to hear from Dr. Johan about models of care and the importance of providing appropriate care for those with the condition. So thank you.
Thank you, Helena. I'm going to start off first with a patient story, and this story is very typical of some of the patient experiences I hear about when I see them in our PCOS clinic. So Megan is a 19-year-old university student, and she revealed a very frustrating road to diagnosis, similar to many women with PCOS like you've heard today. Megan expressed significant distress at needing to see a series of health professionals over 18 months, and she was given really conflicting advice before she was finally investigated for PCOS after persistence on her part to seek a diagnosis. She had really low self-esteem and poor body image related to escalating weight, but also features of acne and excess facial hair. She was initially advised by the health professional she saw to eat less and move more, and to manage her weight without actually any structured support or any actual really helpful advice. Once Megan was finally diagnosed with PCOS, she was then told she had a limited chance of having a family, which then caused more distress. She was given very little information at diagnosis or any support. This information was not only inaccurate, because now we know that women with PCOS have similar family size to women without PCOS. And of course, they might sometimes need some increased medication to fall pregnant. But with all of this misinformation, Megan felt alone, marginalised and isolated, and was then later diagnosed with depression and requiring a break from her university degree. This was a mixed opportunity for an expedient diagnosis, to provide evidence-based information, to provide support and care, and an opportunity for weight gain prevention was also missed, and also to sort of manage her symptoms early on in the piece. And all of these have clearly shown to sort of improve psychological outcomes and quality of life. The sad thing is that Megan's story is not an isolated event, as you've already sort of gathered from today's earlier speakers. Megan's frustrations are really common. So women with PCOS are often dissatisfied with the diagnosis, the care they receive, and the information they receive from clinicians. The majority of women, sadly, don't actually receive any information at diagnosis, or are not even referred to websites that actually have that information readily available. In fact, only about 50% of women actually receive this information at diagnosis, which is what some of our research has shown. And when they did receive this information, it was often really a bit tokenistic, and women often felt that it was quite inadequate and really left women feeling isolated and alone. So in the absence of health professional referred reliable resources, what do women do? They often would go to Google, and can't blame them, to try and sort of find information. But the problem is that this information is non-evidence-based and often inaccurate. And so I think high quality patient-centred care actually involves provision of information to enable women to have accurate information, have quality, consistent, evidence-based information. And also the other thing that's really important is to provide this in the context of evidence-based multidisciplinary care. And this quality information has broad-reaching impacts. It can actually affect patient experience, their understanding, satisfaction, and no doubt it can improve health outcomes. So fortunately, as Helena said earlier, we're now funded by government to actually extend some of the resources and tools that we have developed into actually bring them into clinical care to improve shared decision-making and empower those affected by PCOS. The tricky thing about PCOS is that it's really quite a complex condition. So the clinical presentation varies from woman to woman. One woman might have more reproductive features, another might be more dermatological. Weight can be variable. Not all women with PCOS are heavy and can be lean. And so this adds to the complexity of diagnosis. And To add to this, the presentation in a woman varies across her lifetime. How it presents in adolescence can be very different to how it presents in young adulthood, then in reproductive years, and then in postmenopausal years. So we need to be understanding of what features might affect women with PCOS. I think when providing clinical care, it's also really important to listen to women and to actually understand what the priorities of care are for women and to ensure that these are actually satisfactorily addressed. So a multidisciplinary approach is really ideal, and this has been shown in many chronic diseases to be really important and related to improvements in health-related behaviour. And this has certainly been demonstrated in diabetes. And I have been fortunate this year to actually undertake a 6-month sabbatical through my clinical role at Monash Health. And during this time, I've actually had the privilege of visiting quite a few PCOS clinics around the world and have a few more to visit still. And what is clear globally is that there are very few dedicated PCOS multidisciplinary healthcare centres across the world. The guidelines recommend increased primary care education and multidisciplinary models of care that enables and promotes self-management. Through the NHMRC Centres of Research Excellence and supported by government funding, we have actually had the privilege of establishing a statewide PCOS model of care based here at Monash Health. This service provides education, lifestyle and health coaching small group sessions, endocrine consultations with clinicians experienced in PCOS management, and laser hair removal for troublesome hair growth seen in women with PCOS. This is a multidisciplinary, patient-centred service that provides up-to-date, evidence-based care, directly translating guideline recommendations into clinical practice. This service, we've actually evaluated this, and this service has demonstrated fidelity to guidelines and the ability to meet patient needs. And it also offered some offerings for improvement. So in establishing and evaluating this model of care and visiting centres around the world, the gaps are really clear. We really do need widespread, evidence-based, multidisciplinary, patient-centred models of care around the world that can offer care to the majority of women with PCOS. We need to be able to provide women with high-quality resources, tools and healthcare delivery. And we're working with women and clinicians around the world to scale up the PCOS model of care that we've developed to try and improve health outcomes for women with PCOS. And lastly, I just want to say that it's been an honour and a privilege to work with this amazing team of PCOS researchers, clinicians and engaged PCOS consumer societies from around the globe. It really is a massive undertaking and an enormous body of work. And these guidelines are really there for clinicians to help guide clinical practice, for consumers to have engaging evidence-based resources to help understanding of their condition, improve shared decision-making, and to empower women to advocate for their own healthcare needs. Thank you.
Very well said. And there's nothing better than an event like this that doesn't go over time. I just have a couple of very, very final thank yous to people who've had a very coordinating and important role in the guideline, and that's to Linda Downs, who's actually been the project manager for both Centres of Research Excellence. Linda's now a household name for all of our partners because she's the primary person who communicates with everyone, and Amanda Hamilton, who is our comms and translation lead, who's done an amazing job. So I think the bottom line is we're incredibly privileged in this room, but also around the world and out in the community to have had the buy-in and partnership. And many people have actually said to me, how did you herd all those cats into a barn? In fact, I think you asked me that, into a barn. I said, well, maybe it was like herding cats into a burning barn. But actually, it wasn't that difficult. And it wasn't that difficult because it was all about improving patient outcomes. And given that's why most people work in healthcare and research, once we had the vision and then worked together collectively, it was just about good governance, good process and sticking to the vision and lots of hard work. So on that note, thank you to everybody. Thank you to Carina Garland for attending. And you can see we have lots of work to do to improve our education of health professionals, to get those messages out there, to support women and to help change the name as we move forward, and to work with our partners to implement in terms of a best practice. So thank you very much, everyone, for coming, and go forth and disseminate. I do note there are a couple of very quick questions online which we can take, and mostly just to say well done and thank you. Yes, we're going to go on to TikTok And I know there are some people in here, including Carolyn E, who was one of our very important primary care providers as well. So any questions in the room? They were floored you all. All right, on that note, we will finish. Thank you, everybody, and thanks to those online.